Okay, we are now officially recording. So we definitely want to welcome everyone to the LARC webinar today. It's October already. And a reminder, our next webinar will be not on Wednesday, but on Thursday, November 5, instead of November 4, Wednesday. And then as we were talking with Fortunate yesterday, planning the meeting today, we realized that we are coming to the end of this LARC cohort. So our last meeting will be November 18. So more to come about that as we talk later, but we are really looking at two more meetings. So sad in a way to come to an end, but exciting in a way to see what we've been able to learn and what we can learn for going forward. So 2 more meetings, and we'll talk about the implications of that, but next time on Thursday instead of Wednesday, and then the final a debrief meeting will be on November 18. So here's our pager for today. Of course, we've been working on providing guided approach to QI. And we've been looking at viral load coverage for the past couple of months. So today we'll have some welcome and introductions. We'll have a word from our sponsor, BRTI. Today we have really a special guest and very excited to have a special presentation from our Africaid group on the QI work they've been doing, and really excited to have them share that with us today. So looking forward to that. And then we're going to interview a couple of teams, your colleagues, and see what we can learn about the PDSAs that they've been doing. We're going to have a short learning burst today on standard work. And then we'll talk about what's coming up due on November 5, and that is PDSAs with data. We'll focus on having data with our PDSAs, and we want to focus this time on starting to develop some standard work or SOPs. And then, of course, the viral load challenge that is still ongoing for this month. Want to just focus here on this expected outcome. The expected outcome is that we will have completed some QI projects and that we will have some results to share and some lessons learned. So we'll have, of course, our viral load challenge, which is for 1 month, seeing if we can double the number of viral loads that we've been drawing. And then we'll really look at, for the clinics, the viral load coverage data. That's AIM 3. We should have that data in for the month of October, and we should be able to complete that by November 18. And then final data from AIM 1 and AIM 2. AIM 1, the results in the Green Book, and AIM 2, care according to guidelines. So that's what we're aiming for. And again, by November 18. So we are really looking at the end of our time together. So those are some of the things we'll want to complete. We'll also be sending out a survey to understand what worked well, what didn't work well, and what we should do for the future going forward. So let's do some introductions quickly. I'm going to give you some instructions, and then I'll stop sharing my screen so I can see the screen share. These teams, Hopely, Hatcliffe, Kwadzana, Pari, PSI Lab, Epworth Poly, Mbare Poly, Seke North, and Chitungwiza Central Hospital. These teams, I want them to turn on their camera. Now, why did we pick these teams to turn on their camera? you can type into the chat box, why do you think these teams are turning on their camera? I'm going to look at the chat box. I've got people signing into the chat box. Why do you think these teams get to turn on their cameras first? They've submitted their presentations. Yes, yes, yes. They've submitted at least one. Now, would we have wanted more than one? Yes, but all these teams have submitted at least one. I did get a couple in the middle of the night last night, so these teams have submitted at least one PDSA. So I'm going to stop sharing. I'm going to put my gallery view on, and I want to see those teams turn on their cameras. So let's see those teams turn on their cameras. I'm still waiting to see my screen light up with faces. Teresa from Quadzana, you can turn on your camera. PSI Lab, you can turn on your camera. Jackie, Mbare Polly, you can turn on your camera. PSI Lab, Samuel, you can turn on your camera. Japheth, you can turn on your camera. You've been working very hard. Fortunate, you can turn on your camera. Hopefully, turn on your camera. Let's see, my screen needs to light up with cameras, okay? So, PSI Lab Samuel, turn on your camera. Hopefully, Mr. Nvodu, please turn on your camera. Teresa, turn on your camera. Okay. Where I'm getting ready, we're going to snap our screenshot. So everyone smile and wave. We're gonna snap a screenshot. All right. All right. Still some of you did not turn on your cameras.
Right. Hopefully, Maluli.
Yes, yes. And I'm going to my second page here. Okay. So good to see those of you this morning and this afternoon who have shared, and really glad to see more and more teams are getting those PDSAs going. So just a reminder, one PDSA a week. Now, to be clear, does that PDSA, can it be a refinement or a continuation of the PDSA you've done the week before? Of course. Or you can test a new change. Remember, speed dating. PDSA is like speed dating. You're not married to these changes. So you can test multiple changes, or you can keep building on the change that you've done that's working well. But let's be testing something every week. That's remember, PDSA is not one and done. Okay, we're keep moving. So now let's take a minute and have a word from our sponsor, BRTI, who's going to say, welcome us today from BRTI.
Good morning, everyone. Good afternoon. It's good to see it's good to see you all, and thank you for attending our webinar. I just want to introduce next to me, maybe just remove your mask for a minute so that they can see you. Patience, this is Patience. She has also joined the CLI team. She's on the lab side. She's a lab specialist. So we'll be working closely together with Patience. So you'll be seeing a lot of her as well. So I think with that said, over back to you, Barbara. Thank you.
Thank you so much, Fortunate, and welcome to Patience. I said with patients and fortunate there, we've got the clinic lab interface in the team there. So great to have you on board, patients. We're looking forward to working with you. All right, I've got a quiz for you today. I've got a poll for you. Okay. Here's your poll. What is the most important part of lean design? Quiz question today. Most important part of lean design. All right, 18% of you have voted, so get those voting fingers ready. Most important part of lean design, is it fit and trim, reduce waste, or reduce defects? All right, 71% of you have voted. 78%, so 1 minute, so we'll end our poll. Reduce waste is the winner. Lean design is about reducing waste. For a bonus question, who can type into the chat box what is the method that we use to reduce defects? Okay, that'll be a bonus points there. Fit and trim. It's great to be fit and trim, but that is not lean design. So reducing waste is the correct answer. But what method do we use to reduce defects? Who can answer the bonus question for me? Type into the chat box. Let's see what's happening in the chat box here. People are still signing in. Dignity said to ensure their connectivity is functional. Well, that's a good reason too, but those teams got to turn on their cameras because they had turned in their some PDSAs. Okay, so bonus question. What is the method that you use to reduce defects? What's the QI methodology that you use to reduce defects? I'm counting to 7, waiting. Does anybody know the QI methodology that you use to reduce defects? Lean is about reducing waste. What is the methodology that reduces defects? No one gets the bonus question? Okay, well, you're gonna have to look it up. All right. So I saw this week in a journal I was looking at, and it made me think about lean. Streamlined workflows, streamlined procedures. The future is here. Streamlining, reducing waste, a key thing to really focus on as we're doing these PDSAs. How can we get rid of waste? We have limited resources, limited people, limited time, limited funding. How can we get rid of the waste and focus on the value added piece? So that was a quick reminder. So now the rest of you may turn on your camera. So everybody, all the teams, I'm going to stop sharing and I want to see every camera on now. Every camera. All right, I see NMRL Lab. I see Budrido. I haven't seen the folks from Budrido in a while. Chitinguiza Central. I see Taku today. Hi, Taku.
I see Dr. Cabo.
Ah,
Long time no see. Bobby.
fabulous. What does Dr. Cabo look like? Dr. Cabo, open. I can't hear you. You're talking, but your mic is muted. Say something to us. We want to hear you.
Oh, sorry, team. I'm driving. I'm almost at the office. I'll be
Oh,
joining you in the
drive
next 10
carefully,
minutes.
Bobby.
No, no, no. Turn that off. Be safe. Okay, fabulous. Well, we're going to grab a screenshot now. I think I've just got most of you here. So fabulous. You all are looking great there. Appreciate everyone turning on their screen. Good to see everyone. And I'm actually going to be very sad thinking that we only have 2 more meetings together. We've formed this community especially during this pandemic. So definitely we'll miss seeing you all. So thanks for turning on. Good to see everyone here today. So while you have your camera on, I need you to raise your right hand and solemnly swear that we are going to test some changes over the next couple of weeks. And we are going to have a commitment to show measurable results. So please commit to that. We are coming to the end, and we definitely want to be able to show some measurable results. And I'm pulling from the Ghana's Project 5 Alives, and you see 3 different run charts there, and you see the run charts moving in the direction that they wanted them to move, because these are mortality rates in children under 5. So we definitely want to see measurable results as we move forward. So now we have a special presentation. Very excited to have a guest today from Africaid, Ann Sellberg, and really excited to have her share her presentation today. Before she starts, I'm going to ask you to listen in very carefully and capture 3 things that you think are great practices, or 3 things that you think are really important to a QI project. I'm going to ask you to type those into our chat box, and because I think there's many good things you could pick up, but I'm going to ask you to pick up 3 things that you think are best practices or that you think are really important to QI projects. I'm going to ask you, what would Katie like? Okay, so pick something that you know Katie would really like. So I want you to type those into the chat box. Pick up 3 things as we listen to this presentation. So I see Ann is on. I'm going to stop sharing, and I'm going to make you a co-host so you can share. And at this time, I will turn the time over to Ann.
Great, thank you. Good afternoon, everyone. Please confirm if you see my screen.
We do see your screen, not quite in presentation mode yet, but.
And now?
And now it is, perfect. The time is over to you. Thank you so much for sharing today. And remember, team, 3 practices or things that are important for QI projects. Please pick them up.
And please,
Thank
everyone, sorry, Ann, just make sure everybody else, please mute your mic. Thank you.
So I'll start.
Yes, please. Thank you.
All right, so this will be quite a lot to cover in a short period of time. So I'm going to go through the slides quickly, but if you have questions, we can always come back to the slides and go through them in more detail. But I'll present what we did in a viral load deep dive. Then we started a viral load quality improvement in Shimba and Goromonsi. And then we cascaded that to all Africaid supported districts through CDC, and then share lessons learned and next steps. So just to give you a update. So last year we could see that there was a quite considerable variation in between districts in terms of viral load coverage and suppression rates. So we used the SIMTech data to find the one site that had the highest coverage and suppression rates and a few sites with very low coverage and suppression rate. And we decided to do a deep dive in the one with high coverage and suppression rate, and to set up quality improvement project in the ones with low coverage and suppression rates, learning from the deep dive.
And can I just break in for a minute and ask everyone to make sure your mics are muted? Thank you so much.
And I saw that Ledwin has been scribbling on the screen. So we need to stop that. Thank you. Go ahead, Ann.
All right, great. So the best practices that we saw in Chalotra was one, that they had very strong collaboration between Minister of Health, SIMTech, and Africaid. Clearly defined roles and responsibility, and they had developed a QI plans jointly, which they were following up on. Then they had combined artery field clubs and support group days, where they were bled for viral load and age disaggregated groups. They also had a provision of adolescent-friendly services with staff with non-judgmental and friendly attitudes. And they'd even gone as far as to ask adolescents what they wanted. And that's when they said they wanted to be seen on a Saturday. And then they used adolescent-friendly language. And then there was also good collaboration between community cadres, so the OI nurse would make sure that she refers to the cats and the CLF together. They would go into the community together and split up, and the cats would cuddle with the 0 to 24 and the CLF, the ones who are older. And then if they needed support from another, they would come together also. And then they also did active follow-up and viral load monitoring. So they were setting targets, weekly, monthly, and quarterly targets. So the way we did this viral load deep dive, we first had a discussion with the district health team. Then we had a discussion with the OI team. Then we went for home visits with the cats, and we watched how they did the home visits. We also had a focus group discussion with the adolescents, and then in-depth interviews with OI nurse. So it was quite a comprehensive process. This is just to show you the walls of the OI department. As you can see, they did a fishbone analysis. They had been color coding for the files. They were also doing a chart where they were tracking how many were being bled against the target. And they had set up activities and etc. And this was visible on their walls. What we also did home visits. So we checked on the clients, how often they've been seen by the cats and how they experienced the support they received by the cats. And we also looked at how we can improve and make sure we check on the quality of home visits delivered by the cats. And one other of the best practices that we saw from Africaid side was that Shandira Mentor did weekly follow-ups with the cats, met up with them weekly to track on caseload management and how they were utilizing the tools and supporting their clients. And during this process, we also developed a process evaluation where we not just looking at the data that we had from SIMTech, but really looking at the site level data of how they did the viral load monitoring. And part of this was reviewing the tracking registers to see if those that had a high viral load or those that defaulted adherence counseling were documented in the tracking register. We also reviewed the viral load register to see how many were bled out of the total cohort, and how many were suppressed and how many were rejected. And then we also reviewed patient files to check on, we pulled 10 files at random and checked proportion with valid viral load and proportion that were booked for art refill days. And this was quite interesting because many of them said that, yes, we book them for art refill days, but when you actually checked in the files, they were not booked on Saturdays. And then we also did a review of high viral load registers to check how many received adherence counseling, second viral load results, and was switched as prescribed. And this is the outcome. As you see, there are a couple of not known, and that's there are a couple where we didn't check it because this process was sort of developed while we were going for these health facilities. But one thing that was of note was that most were not aware how many children, adolescents, and young people living with HIV they were supporting. So that was one of the first action points, to go back and actually count all the green files. Separate filings, 3 did, some didn't. And then when we reviewed the 10 to 20 green files, you could see that some of them had good proportion of bled for viral load, but the number of valid viral loads was much lower. And the suppression rate was also quite low in some of them. And then some of them had partly booked for adolescent days, while others had not booked for adolescent days. Then we also checked the high viral load register to check for documentation. And what we could see was also that in one facility, they were delayed switching to second line because the DMO in those facilities were requesting for full blood counts. We also could see that in one in Melfort, there were quite a lot of defaulted viral load management and the delays in adherence counseling. So going through the high viral load registers was very insightful in seeing what was the support giving to the clients with high viral load so that we could address those. And then tracking registers, some did refer for viral load monitoring, some did not. Some assigned CATs for tracking, some did not. So this is how we set up the viral load QI plans. We worked together with Dr. Ricky Malaba, and we gathered the team at the health facility level. So we both had a district minister of district health team staff came with us. Then we had national and provincial level staff from both SimTech and Africaid, and then we sat down with the site level staff. And we first did the review of the viral load documentation, and then we set up objectives, aims, and activities for each of the sites. And here's also where we try to feed in some of the lessons learned from the Chilotro viral load deep dive to recommend them to set up similar activities to achieve such data. So this was the outcome after 6 weeks for the 7 supported sites. As you see, one of the challenges we had was to collect baseline data. So we didn't have baseline data for 2 of the sites. But in spite of this, you can see that we have quite a number of high, at the end of the quality improvement, we have 329, it's 69% that had a valid viral load results and 79% suppression rate. And that's from 64% with a valid result and 45% suppression rate. And 64% is referring to the ones who were bled for viral load. So we managed to increase the number of bled for viral load from 38% to 80%. So good practices from Shimba, they collaborated between SimTech, Africaid, and Minister of Health in line listing all clients eligible for viral load. And they had good collaboration between the cadres, village health workers, community health workers, and CLF, who joined in support groups in the tracking, and also especially if cats were facing challenges with the caregivers. And then CATS had an updated contact sheet of all the community health workers so that they could collaborate better. And then the Shandira mentors actively followed up with the lab. And by doing this, the turnaround time improved to less than a month, except for the ones who went to the district hospitals where they were sent, and there was a longer turnaround time. And then they also introduced joint monthly case conferencing around our clients with high viral load. So every month, the Shandira mentor would sit down with the clinical staff, and they would discuss using the high viral load register all the children, adolescents, and young people living with HIV with high viral load. And by doing this, they managed to reduce quite a lot of the delays that we had seen in the management of clients with high viral load. Challenges was the transport of samples, that sometimes the riders would not come on the agreed dates, and then they would not get transport if the samples were too few. And there was not possible to get transport for samples during Saturdays, and they had art refill and support groups on Saturdays. So clients couldn't be bled when they came for art refill, which of course was a challenge. And then the caregivers, they were collecting resupplies for their children's, and there were unavailability of transport for clients. And then there were some of the samples from October to December that didn't come through, and the lab recommended to rebleed, and that's always a challenge to get people to come back and be rebled when they've already been bled once. And some had difficulty also accessing adherence counseling due to distance. So in spite of this, we still saw quite a considerable improvement. So we decided to cascade this to all the 13 Africaid supported sites, Africaid and Simtech supported sites. So we had our Africaid staff undertake the IHI QI course. And then we collaborated with Simtech for baseline data. And then we planned the first PDSA cycle from mid-July until end of August. And we wanted to achieve 95% VL coverage and suppression rate. That was a, but we made it, we wanted to increase viral load coverage from 50 to 80% and to improve viral load suppression rates from 80 to 95%. Those were our objectives for the 6-week PDSA. And the activities was to line list clients who are due for viral load bleeding, virtual mobilization of those due for viral load bleeding, feedback to facility nurse for the ones due to come the following week, supermarket approach where they would, when they came for artery field walls, made sure if they were due for viral load bleeding, they would also be referred for those services. And utilizing adolescent days, viral load search activities, viral load outreach activities, and even door-to-door bleeding. Those were the activities planned. And these were our results after 6 weeks. So as you can see, 50% coverage by the beginning of the 6 weeks, that went up to 64% coverage at the end of the exercise. And our viral load suppression rate was basically the same, but we managed to bleed 2,121 clients. So we didn't include all the clients, we only included about half of our cohort. We support about 23,000 through Africaid, so we included 15,000 across 79 sites. And we still had 1,137 results that were pending at the end of the 6 weeks. So some of the best practices that we identified was the review of all green files for line listing and viral load results, viral load surges and outreach for viral load bleeding, ownership of viral load QI process by entire viral load QI team, and this was only achieved in about 3 districts. Direct follow-up with lab for viral load results, and provision of virtual adherence counseling together with PC and CATS. So we trained our Shandiri mentors and Shimba districts in how to provide virtual adherence counseling in order to make sure that those that live too far away can still receive those services during COVID. And this training we did together with Minister of Health. So it was a joint intervention, or how to say, initiative with Minister of Health to train cadres for virtual provision of adherence counseling. So the lessons learned is that you need to engage clinical lab partners for joint ownership of the QI process, target, and goals. And then to set realistic targets that are appropriate for the given timeline and weekly follow-up of targets. So to have targets around viral load suppression rate was a little bit unrealistic, considering that it takes at least 3 months to go through the adherence counseling process. And then they need to be rebled. So we wouldn't possibly be able to have an effect on that in a 6-week period. So for the next viral load QI process, we set targets on ensuring that all those with high viral load get an adherence counseling session. So it's more looking at the delays than looking at the suppression rates. So looking at the process indicator. So some of the challenges that we faced was that clients were supplied with 6 months ARVs, which meant they would not come back to the health facility until September, October. Also that many of them had joined CARGs, so they were not visiting the health facilities. And long turnaround time and lack of PPE among healthcare workers made healthcare worker staff reticent to do the viral load bleeding. There were also some district-specific challenges that caregivers would collect for their children during adolescent days, even when they were booked for adolescent days. And that our clients that came outside of review dates were not assisted in some health facilities, they were sent back. Then in Kadoma, the transport of samples was inconsistent, so some of the samples were discarded. In Lupana, Chiloch, and Hurung, where they had lack of DBS kits for viral load sample collection. and Lopan and Shimba had shortage of EDTA tubes. Mazoe and Harare, they had challenges with clinics shutting down due to COVID-19. And in Seke, the bleeding spaces that were done when they did door-to-door bleeding were not conducive for adolescents because they were too open and they were afraid of involuntary disclosure. So as a follow-up, we discussed, we had a meeting with our lab partners, BRTI, CDC, and Simtech, where we shared, we agreed that we would share the list of clients with outstanding results, and that would connect our Shandiri mentors with the lab mentors, and ensure that our Shandiri mentors have access to viral load results via email as a clinical partner. And then we discussed also to at least initially have monthly collaborative meetings, and to include lab staff in QI meetings and outreach activities. And then we also had a meeting with the Simtech QI team, and there we agreed that we need to arrange a meeting with the DHE to ensure all players are on board, including lab, and that we need to triangulate viral load results for documentation and follow-up. So there were some questions shared with me by Barbara before I did this presentation. So I think I've answered some of the questions. I think what we did when it comes to spreading the best practices, I've written a quite comprehensive report, which received some feedback from Dr. Francis Petrarca. So I'm still working on those feedback before I'm able to share the final report from the viral load, the initial viral load QI and the deep dive. But we've shared it in various forums, and I'll also share it on the adolescent workshop that's planned in Namibia. So there'll be a virtual presentation around this also. But we've shared it with our staff and shared the best practices. So, and then how did you achieve these results in the midst of a pandemic?
So Ann, let me just jump in here if you don't mind. There was a
Yes, of course.
key points I just wanted to highlight on. I think at the very beginning, you talked about this Xolotso site. How did you see that site was doing better than the other sites?
So we use Simtech data from last year. So from that data, we could see that they had 91% coverage and 94% suppression rates. So that was the top performer of all the sites.
So I think that is really a key point. Sometimes you also looked at the sites that weren't doing well, right? But I think that that's a key point. If someone is doing well, and of course, data underlies all of our discussions, but if someone is doing well, why not go and see what they're doing that's working well? So I think that was a key point that I wanted to make. And then Ann shared about how she did the deep dive. So I believe you said you went there, you talked to people, you went on visits. How did you really capture what was working well in the deep dive, Ann?
So we did like all levels. We started with the DHE, with all the different players, discussing with them how they supported. And we had also created SOPs around which questions to ask. And then we talked to the OIR team. And then we talked to the adolescents with focus group discussions. We talked to the cats. We went home for home visits, talked to the clients and the caregivers in the home visit, watched how the cats did the support. And we also had in-depth interviews with healthcare workers. So we had developed this method before we went out, like how we were going to tease out what questions to ask and who to involve in what way.
So I think that's also a practice that we certainly could capture, and I think you've already developed an SOP, but very important on this deep dive to kind of really understand what's working well and why it's working well. So, and I was interested in your list of best practices, but and you talked a little bit about how you spread that, but share just a little bit about how you would spread those best practices to other sites once you had kind of captured them.
So we did that through, so first of all, we did the Chilocho deep dive. And then when we set up the QI plans, we also discussed with the QI, site level QI teams on what they did in Chilocho. So we shared it locally with them, but then we also had a presentation for staff. So Shandiri staff, we had a presentation about the deep dive and our findings from the deep dive. And we've done that several times in different forums.
Mhm.
And then also the report that I've written, which hasn't been shared widely yet because it hasn't been completed after the feedback I received, sadly. So there is a very comprehensive report with everything documented more. So hopefully within the next month, I'll be able to share that also.
But you
And then-
actually, you went to the sites or you shared virtually with the sites about the best practices?
So for the Shimba and Goromonsi, we went to each of the QI sites, and then we also shared about the best practices that we've seen in Chilocho.
Okay, excellent. And I am really, my hat's off to you to achieve these results in the midst of a pandemic in 6 weeks. I mean, I don't think if any, maybe some of you did not catch that, but this is July and August in the midst of a pandemic in 6 short weeks. So what's the secret sauce here, Ann?
Well, I think the secret sauce, I mean, it's quite a simple concept. It was mainly that they went to the health facility, the line listed, and then had the cats mobilize people. And when you come for your ARVs, then you'd also make sure to mobilize them for that. But I'd say for the ones where it was the most successful, because there were some districts that really had a successful outcome, like Mazo and Mount Darwin. The secret sauce was that they also did the collaboration with all partners, that they had Minister of Health and SimTech on board and lab even. So when they went out and did the viral load outreaches, they had lab with them in the car. So to have all players on board to do viral load outreach and then the line listing, I think those are the main key secret sauce ingredients.
So were these people already in the facilities, or were they, you know, kind of a team came together?
The viral load QI team, you mean?
Was that were these people already in the facilities, or were these people who were coming in to assist with this particular activity?
So from Africaid, it was only the district level staff. We didn't do any support visits during COVID. But I'm not sure from SimTech if they had support on their part. But from what I know, it was only the district level staff who were part of that.
So I guess my question is, were we using the staff who were already in place, or were we bringing in some extra help to sort of jump in and focus on this activity?
I think, I mean, they were working together with the nurses. And also for the line listing and updating on the viral loads. When they did outreach activities for bleeding, it was different in different districts. Some of them, they brought the site level staff. Some brought district level staff to do the bleeding. So I won't say it was the same across all districts how they did that. I also have Priscilla on this call, and just to say, Priscilla was the one who really spearheaded this entire process. So maybe Priscilla, you want to come in and also share some on these questions?
We welcome Priscilla.
Hi, thank you. So like what Dr. Ann was saying, we didn't have any additional staff. We were working with the district staff and really following up on a weekly basis. We'd had weekly calls. We would tease out the data to say how many, what are the issues, and try and troubleshoot problems on a weekly basis.
So I heard a couple of key factors there. One, you talked about data. So my next question is, how did you have such impressive M&E? You looked at 4 different data sources. How were you able to get that data? Because we all know that there is no QI without data. You can't identify a problem without data. You can't target it and work on a problem without data, and you can't know that you've done improvement without data. So how did you get that, that level of data?
So it was all from the green files, the line listing and finding out who had been bled. And then the being bled was from the viral load registers. I think the challenges we had was to find out the ones who had been bled, like to get the patient level data of viral load bleeding. Priscilla, do you also want to come in on this question?
Yeah, Priscilla, this is an important question. Who is actually looking at those 4 data sources and being able to provide that data, because that's actionable data. So tell us a little bit more about that.
Yeah, thank you. So for the deep dive, since we were at facility level, we were then asking the nurses to say, so what sources of data do you use to record viral load, for example? So apart from the patient green file, some had improvised registers for viral load. Some were using the Ministry of Health, the stubs. So we were also then asking the facility to say, if I wanted to know how many people have been bled in the last month, what data source do you use? Because at the moment, there are different data sources that are currently being used. And for the subsequent QI activities that are being done, the district level staff were working with the disclose, the ITEC, the Syntec disclose, and they're also working with the facility level nurses, where they would also ask to say for this week, how many have been bled using the facility level data sources. So that's how we're collecting the data. So the ones that were reported to have been bled, we're also coming from, we're verified by the facility nurse to say these were the ones that were bled this week. And if you could go at the facility, you would get the same numbers from their data sources that they're using to collect the data.
Okay, it's an impressive effort to collect that much data, but it's so key, so key. And take me.
So can I ask a quick question to Priscilla?
Yes.
Okay, so Priscilla, just curious. So this sounds, is this a special project, or are you planning to make this data collection to help with your improvement on an ongoing basis, the sustainability part of it? Over.
Thank you. So yes, we would want to be able to take the lessons and the gains made and to be part of our programming. So we were finding out that in our own program, in terms of viral load data, which is actually a very key component, we were lagging behind. So all of these lessons learned, all of these best practices are going to be scaled up and implemented in our normal programming. So we do intend to, sustain the gains.
Hello.
Hello.
Yes, I've been raising my hand. It's Dr. Junior, as you call me. This is quite impressive. Coming from the lab partner, with those questions in mind, this is quite exciting and well done for that team. But I wanted also to find out in terms of the lab, what sort of best practices were done, and who exactly were you working with? Because I know Cholocho is not a testing site, and our testing site has several other testing sites. So would also want to see what we did well for that facility, which we can also replicate elsewhere, even within the same province. Thank you.
Thank you for that question. I think for Cholocho, it's not the same. This data is from Cholocho District Hospital. It's not the same over the entire district, but they have a machine there where they can analyze results. And then they also had very engaged lab staff who even sometimes would put in night shifts to make sure that they utilize the machine all over 24 hours. And then they also had a very strong collaboration. So the lab staff, between lab staff and Ministry of Health staff. And they had opportunity to bleed over the weekends. So I think, of course, that's a bit of a special situation for Chaloche specifically. But I think best practices, like what we could see, is the more the lab staff are involved in the QI process, the best their results. Like we can't really do this QI without having the lab partners on board.
Okay, thank you very much. Maybe with my colleagues that are on the call, we'll try and extrapolate more so that at least we can be able to granulate this information and see what we can also roll out to other maybe similar situations, because this is quite exciting and well done. Thank you.
Thank you,
Thank
Dr.
you.
Junior. There's a question from Fortunate, but before we get to that, Ann, can you go back a few slides to where your results were? Can you take us back just a few slides? Back. This one, this slide right here. Nope, sorry. The previous one.
Even before that.
No, the one you just went past. It would be after this. It was after that. Yeah, this one. So a couple of things caught my eye here, and when Dr. Junior talked about the lab, I see that 54% of the results are still pending. So I see that you have worked with lab, but I think that there's an opportunity there for sure. The other thing I wanted to point out here is your results, your viral load suppression. As you pointed out, 6 weeks is not enough time to change that. So it pretty much stayed the same, and your coverage went from 50 to 64%. So these, and Katie and I talked about this yesterday, these results look realistic to us. Sometimes when we see results, where people are all of a sudden at 95%, you wonder. These results look like real results where you've, there are 15,000 cases here, but appreciate that, you're moving it up slowly as you would in real life. So these results look realistic. So
Can I ask a question, Barbara?
yes, and
So
Fortunate has one also.
okay, so the viral coverage from 50% to 64%. The definition of viral coverage, is that the PEPFAR definition, meaning not just a sample that was tested, but as the test result is recorded in the Green Book? Can you clarify, please?
I think this talks about the number bled, not the. Is it coverage? Wait, end-line coverage, valid results. This speaks to, you have end-line coverage and valid results. This speaks to the percentage bled, not the percentage with valid viral load results.
Okay, thank you.
I see there is a question from Fortunate. Fortunate, do you want to open your mic and ask the question? While Fortunate is opening her mic, it says, Ann, how did you manage to do virtual EAC? Did you buy data for the patient or what?
Sorry, can you come again?
How did you manage to do the virtual EAC? Did you buy data for the patient or what?
So it wasn't done through data, it was done through calling, so the normal way. Of course makes it quite costly. So we did first a trial with 600 mentors who were trained, and then we worked with Minister of Health to train Shimba and Mwenezi. And I think for some of them, what we've seen, for some clients, it's been working very well. They're very happy with it. With others, you need to be more on site to really get the challenges they are facing. So what we've been propagating for is a differentiated approach, where sometimes you do an outreach adherence counseling, and sometimes you do a phone call adherence counseling session, and sometimes you need to call them to the health facility.
But I think that calling also requires data, right? Or
No, not if you call the normal way. So it's only if you called over WhatsApp, you need to provide the other person with data. But if you call normally on the phone, it's just you paying.
Did that answer your question, Fortunate?
Yeah, it's answered, because I thought it was actually a virtual call, a Zoom call, like a Zoom call, a WhatsApp call, something like that. So if it was just a call, I understand.
So the EAC is done actually individually. You are not convening a group, right? So it's one-to-one.
Exactly.
Okay, so PSI Lab Thomas has put in his 3 things, and I hope others of you will put those in. Clearly defined roles and responsibilities was number 1. Number 2 is a joint development of QI plans. Great pickup there, joint development of QI plans and robust M&E. As we've all noted, data is so key to doing that. So others of you, things that you noted, and I'd like you to go back to that page of the picture of the boards in the organizations.
The boards?
Yeah, the what you
The
saw
learning
on
board
the
where
wall.
you show the data.
Taku has to jump off.
Say stop when I come there.
This not yet.
Not yet, yeah.
This one?
No, but
No, it's a picture.
it's a picture of the wall, what was on the wall.
This one.
No, this one. Yes,
Right
this one.
Mm-hmm.
So nope. Yeah, that one. Perfect.
This one.
Great. Okay. Oh, the one of the pictures. The one you just had, yeah, there we go. That's it. There's a little lag, I'm sure. What does anyone notice on this wall? Tell me something that you notice on this wall. Specifically, what would Katie want you to notice on this wall? What do you notice on the wall in the clinic? I'm looking at my chat box. Get your fingers ready. You're typing. What do you notice on this wall? A run chart. Samuel, candy, candy, candy. Fabulous. It's a run chart. And what else? What is specific about the run chart? What is specific about the run chart? Is this run chart generated on an Excel spreadsheet? I'm looking at the chat box. Is this run chart generated on an Excel spreadsheet? I'm waiting. Hand-drawn run chart, Pajani. Fabulous. It's a hand-drawn run chart. It doesn't have to be anything that you need to do with an Excel spreadsheet. It's hand-drawn. So color coding run chart. Yes, beautiful. Fishbone, an activity list. Great things to notice here. So appreciate you all pointing those out as well. Other questions please type into the chat box, or you can just open your microphone if you have other questions for Ann or patients. Other questions? And take us to one of your results charts with the color coding and the.
This one or this one?
The one with the results.
The one from
Yeah,
Shimban
this works fine. Anyone notice, what do you notice about this presentation of data here? I just want to point out here the color coding: red, things are not going well; yellow, things are a little iffy; green, things are where you want them to be. A nice presentation there, and strong work. So other questions for Ann or patients? All right, well, and I want to see more of your list. I only saw one person who told me 3 things that they picked up from this presentation. Thomas from PSI Lab, they seem to have major challenges with transport. What would they recommend in future to ease it, or in other areas? So question about this transport major challenge: what would you recommend in the future to ease it, or in other areas?
Well, I think we discussed that also with the Simtech QI team, and they were saying that it's really important to have the entire team on board. Like, you need to have the clinical partners, the lab, all of them should also be part of the QI process, so that they prioritize and you can work around solutions for these things. I think one of the challenges was that we ran the QI project, but we didn't manage to get the entire team on board.
Well, we all can certainly relate to that. Really takes a team effort. So thank you. All right, I don't see other questions, but if they come up, we'll send them to you if they come up in the chat as well. I want to, let's give a round of applause, and you all have reactions, so you can give a round of applause to the whole team. We thank Dr. Ann for presenting it, for patients, and really the hard work. We in QI know how hard it is, and to get results and to be able to show results, it's fabulous. So thank you so much for sharing. We really appreciate your time and efforts. And we'll, if there are any additional questions, we'll follow up. So thank you very much.
Thank you so much.
Thank you so much, Ann.
Yes.
Thanks for giving us the opportunity to share also.
We're very.
And do share your final report with us. It will be much appreciated.
Absolutely, I'll do that.
Thank you so much. I also noticed that some of your team members took the IHI courses, so that's fabulous. Great. Okay, well, if I can have the screen back, I will share, and we will continue on. We definitely want to get to our colleagues having a chance to share today. So of course, we're working on AIM 3, improving viral load coverage. We want to complete the QI project, but we want to provide better coverage for our clients and patients. So we're talking about PDSAs, and we're going to interview some teams. So Team Mbare Poly, who's going to present today from Team Mbare Poly? I know Jackie's the coach. Who's going to tell us about what you all have done, your PDSA? So Jackie, are you going to talk to us or one of your team members?
Hi, Barbara.
Hi, Jackie.
Hi, Barbara. Actually, the team is engaged with the meet. The team is engaged with the meeting.
So if you wouldn't mind just going ahead, giving us a quick, 3 or 4 minute overview of what the PDSA that the team did.
Okay, yeah, sure. Let me I'll give it. Okay,
Jackie,
so
there's
this
a lot of
is
echo. Maybe there are multiple devices. I don't know.
What did you say? Can you hear me now?
Yes, that's much better. Go for it, Jackie.
Okay, so I'm presenting on behalf of Team Mbare. The team is engaged in something else this afternoon. So we're looking at aim 3, and that is improving viral load coverage. So we were to describe the first or the next step of test of change, and we chose the indicator of reminding of appointments. So how we're going to do it, or how we're describing, was to go through the September cohort and identify clients who are due for viral load. And the second step was to document contact details for clients due for viral load. And the third step was to send SMS reminders to report to the facility for viral load collection before the 30th of September. So the main person who was responsible for this activity was the viral load focal person, although she worked hand in hand with another 2 cadres, which was the OI nurse as well as Sister Bangano, who actually assisted in sending out the SMSs. Due date for the first indicator of identity of September, and it was going to be done in the OI clinic department. And then documenting contact details for clients due for viral load after identifying them in the September cohort was supposed to be done by the 18th of September 2020. And then sending out of reminders to report to the facility for viral load collection was supposed to be done before the 21st of September 2019. And then the list of the tasks needed to set up this test of change was, there was need for a list of clients that would need to have the SMS reminder sent to them. And there was need for airtime for doing the tracking or sending of the reminders. The responsible person was the viral load focal person, and this was supposed to be done by the 21st of September. And the prediction that the team had when the test was to be carried out was to have a high turnout of clients who will report to the facility, determine if the prediction succeeds, and to remind of viral load bleeding versus the number of clients who reported to the facility for viral load bleeding. And then we're to describe what actually happened when we ran the test of change. So we managed to identify 474 clients in the September cohort who were due for, the team managed to send out 193 SMS reminders. Some of the challenges were due to insufficient airtime to send out the reminders. And then in the 2 weeks, 101 clients from the 193 clients that had an SMS reminder sent actually turned up for the viral load sample collection. So that calculated to 52% of those that actually had an SMS bled for viral load. And then describe the measured result and how they compare to the prediction. So we did not manage to achieve the 95% targets that we as a facility had set, because we were expecting to at least achieve 95% of the 193 clients that had an SMS reminder sent out to them. but we only managed to get 101 clients of those, which translated to less than, or no, just about 50% of the target that we had actually set.
So Jackie, thank you very much for that presentation. What is your next iteration of this? What is your plan to move forward to next?
I think the team, after discussing with the team, we wanted to adapt the work plan or the change idea that we had, because I think we did manage to reach out to some clients, although we did not meet our target of 95%, but we felt that this test of change was working. Clients did respond to the SMS reminders that were sent out. So I think as a team, we're deciding to continue with the SMS reminders. Yeah, and then maybe send out the reminders, adapting or maybe changing in terms of when the clients are supposed to be reporting to the facility. Because when we did send out the reminders, the SMS reminder was just that clients should report to the facility for a viral load sample collection, and there was no date specified for when the client should come. So maybe if we're to tweak this idea, maybe we would actually specify a certain date, and maybe even go further to actually ask the clients to come through in the morning and have their viral loads done as well.
Okay. So questions from the other colleagues? Do you have questions or thoughts for Jackie and the Mbare Poly team? And I'm gonna open the,
Barbara, there are two hands there
okay.
from Japheth and Chiesa.
Okay, beautiful. Shafet, go ahead.
Okay, thank you, Barbara and Katie. Thank you, Jackie, for the presentation. I just want to find out the 474 clients in September cohort. Is it the whole cohort for clients that were initiated in September, or clients that were initiated in September for a particular year? Can you just clarify the 474 clients? I just feel that the number is a bit high for a cohort of a particular month. May you kindly clarify the September cohort that you are referring to? Over.
Exactly. Okay, Japheth, thank you for the question. So just to clarify, this is September for all the years. So we were looking at September 2019, 2018, 2017, going back, dating back to up to 2000 when the HIV program started.
Wow.
Okay.
And to actually add on to that as well, this is just for the clients that did not have a viral load sample collected in September. So this figure would have actually been more than what we actually recorded, but because we only took information for clients that had not had a viral load yet done.
Okay. Chiedza has a question.
Yes, I do. I think one of them, Jackie has just responded. I was going to ask if the 474 are the ones who were eligible. So I think that one she has responded to. And then my second question was there like a step-by-step process or some kind of algorithm which you were following? Like, let's say after you send the first SMS, how long before you send the follow-up SMS, or how long did you give the client before they gave a response? Or maybe like, to say we will send a series of 2 SMSs, then if both are not responded to, we then follow up with a phone call. So that's the first question. Was there like a step-by-step process to contacting clients and receiving confirmation of attendance? And for those clients who had confirmed that they were coming to the facility, was there any special fast-tracking process at the facility? Was there someone to receive them, like maybe one of the lay cadres, just to first make sure that we don't miss anyone who has confirmed that they are coming? Just a little more detail on those elements. Perhaps they could help you in your adjustment process. Thank you.
How the process or how we did this was on Wednesday, I think soon after the learning session 3 that we had, the primary counselor, who's the viral load focal person, went onto site on Thursday, and she's the one that went into the September cohort for all the years, like I mentioned, from 2019 going back, and trying to find any green book of a client that did not have a valid viral load results inside. So after she did that process, as she was doing the process, she was actually documenting clients, taking all the details of the clients that did not have a valid viral load that were in the September cohort. So after documenting all these details for the client, that's when she was assisted by the OI nurse, as well as the deck. Sorry, I'd forgotten the deck also. She was also part of the SMS reminder, sending of SMS reminders. So they had 4 days actually, because they actually worked through the weekend as well, trying to meet the deadline. So that's when they managed to send out 93 SMSs. So as soon as they send an SMS, they would document, and once the phone recorded that the SMS had been delivered to the recipient, they would have taken it as the client had seen the SMS. So end of day on Wednesday, when that was when the deadline was, because we had expected to finish this process by the 21st of September. So end of day on Wednesday, that's when the viral load focal person now went into the viral load, improvised viral load book, to see if the clients that she had listed had actually come for viral load bleeding. So there was no special preference for anybody who had come for viral load. They would just present themselves and tell the facility nurses that I've come for bleeding for viral load. And the process would have just been to document or write their lab request form, and then send them for bleeding, and then they were on their way.
Okay, did that clarify your question, Chietza?
Well, yes, I think it's a bit clearer in terms of so I guess you guys had a deadline, which is maybe why there's no like additional steps of following up, or is that like going into your plans now that you're going to follow up on those who didn't come and continue going down the list?
Yeah, I think that's the next step. Like you did say, Chietza, at least your questions were actually an eye-opener of some of the things that we may have missed and that would want to actually add on to our next change plan. Because like you did say, to follow up on the clients that did not actually come, and also for the difference of the, I think 200 and something clients that we did not manage to actually send SMS reminders to as well.
So Katie has a question?
Yes, I just like to make sure I understand. So you went, I was very impressed. They actually went back to all the September cohort for the previous years, not just a year back. So that was great. My question is that, so this doesn't mean that those clients who do not have result in their green book means that they never had a viral test done, right? It could also mean that they had it done, but the results were not recorded in their green book, right? So how do you?
No. Okay.
Go ahead.
Sorry, Katie. Okay, carry on.
I just want some clarification, because if you don't always record the results in the green book, so without result does not mean that this person does not have viral done, right?
Oh, okay, let me answer that, Katie. Because actually what they do is when a client comes for bleeding for viral load, they just record like, if the client comes today on the today's the 21st, we actually just record in the green book that, that the client was bled for viral load. And then when the result comes, that's when we just slot in the result. So if you just find the column or the section in the green book where it says viral load and it's got a date in it, it means that the client was bled. But if the result is not actually documented in the green book, it either means that the result has come to the facility and hasn't been documented in the green book, or the result has not yet reached the facility.
Did that answer your question, Katie?
Well, so if this client was actually came from 2 years ago, but he was bled, but there was no result in the green book, do you still ask them to come and get rebled and so you can test them again?
Yeah, because for 2 years, Katie was saying it's such a long time, and for us to now follow up with lab and say we're expecting a result that was bled like 2 years ago, and yeah, because a 2-year-old result is actually not valid anymore, so we were to bleed the client again.
Thank you.
Okay, so I don't see any more questions in the chat. I do see a thank you from Japhet for the response and a thanks, Jackie, great initiative from Chiedza. And I want to echo that you guys working through the weekend, going back, identifying 474 clients, a lot of work. So I want to give you a hand of applause for that extensive work. I know that's your first test and you have things that you will continue to add, such as the following up of the other clients. So just very, very briefly here, some suggestions. Go ahead and name your initiatives so that we know, a short name so that we can know, SMS reminders, that's helpful. And then I was suggesting that you would put an actual number in there. Just a reminder from Dr. Berwick, who is the President Emeritus of IHI, some is not a number and soon is not a time. So high is not a number. So go ahead and put in there the percentage. And then you had the correct idea here, but just go ahead and write it as the actual numerator and denominator that you're going to use to collect your data. And then go ahead and put on here what you're going to modify, how you're going to modify for your next plan. And then as Chiedza so appropriately pointed out, perhaps a following PDSA would be, how are you going to then again follow up those people who did not come in and you did not reach? Great suggestions, and this is why we share, because we hear great things from our colleagues. So appreciate that.
Barbara, there is a question in the chat box. Do you want to entertain that, or do you want to move on to the next?
We're going to have to ask for a little bit extra of your time today, but what is the validity portion of the viral load result from date of sample collection? Dignity, who is that question for? Is that must be back for Ann? The validity period for, oh, no, you're just asking what's the validity period for a viral load result from date of sample collection. So can someone answer that for a Dignity? How long is a viral load result valid? Dignity, we will wait. Probably someone will put that answer in the chat. I also have to note from the chat that the winner of the question award goes to, I did have a winner of a question. Zwashi says 6 Sigma. The question was, what QI methodology deals with decreasing defects? And that's 6 Sigma. So candies to use, Zwashi. Great. And then there's a new message here in the chat box. 1 year from date of collection is what is being reported here. If there's anything different, please chime in on the chat box. Zwashi is getting some applause there for the correct answer to the quiz question. We are at an hour and a half, but I would love to have a few more minutes. If you all need to leave, I certainly understand. But if you can stay by, we have another report from another team, and it's a great learning opportunity. So I will ask Seke North to go ahead and share their PDSA. I know Fajani is the coach. I'm not sure who's going to share the presentation. And we'll give a short 5 minutes here, and then we'll have time for questions. So who will be sharing from Seke North? Fortunate, do you see anyone on from Seke North who will be sharing?
Hello, everyone. I'm not sure. I think someone is coming on. I think Miriam is going to share.
Hello, everyone. Hello, everyone. Hello, everyone.
We do have an echo there, Miriam. I think it's probably maybe a couple of devices have their microphones on. Try again.
Hello, everyone.
We still maybe have another device that's on. Try again.
All right, we'll try to rectify.
If you just turn off the microphone on the other device, you should be okay.
Can you hear us now?
I do hear you still have that echo. You can't just mute the device. You have to actually turn off the speaker.
All right. Hello, everyone. We are Seke North Clinic.
Very good. So Miriam, please go ahead. I'll turn the time over to you. You have about 5 minutes.
Okay, thank you. So I'm Sifas Chisaka. I'm sharing the screen with Miriam Mukucha. We are from Seke North Clinic. In our initial PDSA, our aim was to increase proportion of eligible patients with a viral load test result from 85% to 95% by the 15th of November. So we worked on the appointment system, and the responsible person for that was the OI ATNES, and we had a deadline of 25 September, and this was being done in the OI AT
just to save time, you don't have to tell us exactly who the responsible person is. Just focus on what you all planned, what you all measured, and what you all what your results were. Thank you.
All right, thank you. So we planned to avail a list with clients who were due for a viral load. So we printed it out, and we availed it to the cadres who are working with a viral load sample collection. We had our primary care counselor send SMS reminders to the clients who were due, who were on the list. And then we had the community referral facilitator track all the cadres who were missed. Our prediction was that after having done the change intervention, we would reduce number of missed appointments from 30% to 10%. And our metrics were number of patients with a viral load appointment and number of patients who kept their viral load appointment. So actually wanted to see of those who were due for viral load, how many were going to come. And the process, we printed the list and that listed 300 patients who we deemed, whom we saw that they were due for a viral load. However, we had challenges with availability of airtime, so we only managed to pull about 30 from that list. And of those 30, 22 came. So 27% still missed their viral load appointment after the reminder system. Of those who came, the indications were that they appreciated the system, they appreciated the reminders. And we saw that the plan improved our turnout of patients by 3%. So in as much as the improvement gap looked as if it was small, we adopted the plan since we know that was it for availability of airtime, we know we would have had more of our clients coming through. Thank you.
Thank you very much, Cephas. So questions from your colleagues.
Okay.
We will listen out for questions. We have some more information about validity period for viral load results. Cephas says 6 months for populations like option B plus mothers, 1 year if suppressed for general population. So thank you for that. Questions about the PDSA that the Seke North team tried. So Katie says, turnout improved by 3%. What is the baseline? A question from Katie. So Cephas, turnout improved by 3%. What is the baseline and how was baseline determined?
You mean Miriam?
Well, I think Cephas said he was presenting, but
All right, so in our planning phase, we estimated that we were missing about 30%. So when we implemented our change idea, from the population whom we worked with, we saw that we then missed the 27%. So the difference was 3%. So that was, we considered that the improvement, we considered that an improvement. Since there was a decrease from 30% to 27%. The baseline, going back to the baseline, 30%, we estimated looking at how our people come through to the OI department using our attendance registers. Thank you.
okay. So Katie says, thank you. Just to clarify,
Okay,
I'm sorry, who's presenting? Is it Miriam or Cephas?
It's Cephas, but I'm sharing the screen with Miriam.
Okay, I thought you had said that at the beginning, so I just want to be sure. Okay.
Sure. Yes, I did say that in the beginning. We are sharing the screen with Miriam. Remember, we were having that echo, so we removed the other devices from the room.
Thank you. Okay, any other questions for this team? I think the questions that Chiedza asked of Jackie may also be apropos here. The question was, what is your follow-up plan for those missed appointments? So have you any thoughts about that?
Thank you for the question. So after having implemented the PDA, this initial PDSA and having observed the results, we moved on to identifying a VO champion, a viral load champion. That's what we did in light of the results from the initial PDSA. And we are looking into other change ideas which can strengthen efficiency in the viral load collection process. Thank you.
Thank you, Cephas. There's a message from Dignity at BRIDH Lab. Baseline data not clearly defined, need to establish factual baseline based on metrics, not an approximation. So that's some thoughts for your team, some information shared there. Any other?
Okay.
Yes.
Okay, thank you. We have taken note of that.
Okay. Other thoughts from other team members? This is really what a collaborative is about. Your team members learning from each other. So we've seen a couple of different thoughts and ways about using the SMS system today. So just some comments that I'll share, and hopefully others will continue to come in. Again, I'll say the same thing I said to Jackie, tag on something in the title so we have a quick way of referring to the test that you did. This would be appointment system SMS reminder. I wanted to give thumbs up, and because your test involved appointments, you predicted about missed appointments, and your measure had to do with missed appointments. I received some some presentations to review, and the test and the prediction and the measurement were all three different. So it's important to keep this in line. If your test has to do with appointments, you're predicting about missed appointments, and your measure has to do with missed appointments. Those all three need to be connected.
Barbara.
Yes.
So quick question. So the denominator is number of patients with a VL appointment or number of patients who receive an SMS. Are they the same thing? Appointment entail like a date or time to come in, right?
So that's a good point. I think in this case, you really only use the patients who received an SMS. So I need to update my comment there as well. So thank you. Yes, and go ahead and put it in a numerator denominator fashion so you can calculate it. But in this case, what you actually did was, as Katie pointed out, number of people who received an SMS. And you said here number
or even number of patients you sent a SMS. They may not receive it, right? If you have the wrong number.
Okay.
You don't know.
Good point. Good point. And you had kind of done it here, number of patients who kept their appointments, but then you phrased it in terms of missed appointments. So again, just a little flip there. Also appreciate data, and appreciated this very much about Mbare's presentation, is that you have actual data. If you send me a PDSA and you've not actually collected any data, I will send it right back to you. My question here is, how many of the 270 not reminded came for an appointment? I think that would be, important to find out as well. And then, as Chiedza pointed out, really have to have another PDSA about how to follow up. So what are you going to do next? Follow up, and then how will you design your next PDSA? What are you going to do about the issue of airtime? I heard that from the two different presentations today. So that is, really a question. And if this is going to be a sustainable option, you know, it seems to have, you got 73% of the people to come that got an SMS. Jackie had a much bigger number in their case, but they got 52% of the people to come. So it does seem to have a great potential, but what are we going to do going forward about the airtime issue, sustainability? So really key questions that I want you all to think about as you're doing your PDSAs. And I'm sharing this again, and I thought it was apropos. We found that what is needed is often known and well documented. So we really have a key understanding of that SMS and reminding people of appointments seems to work. But we really, this innovation requires successful implementation, often lies in the how. So how do you get this done? How do you do it? So that's why our teams have shared what they have gone through. But that's really leads us into our next topic, and I'm going to skip the viral load challenge for a minute, of standard work. And we're going to go through this super fast, but once this is the how-to. Standard work is the how-to. So I'm going to give you a quick polling question. Okay, here's a poll. What is standard work? We need to have an understanding of the topic we're talking about. So get your fingers ready there. What is standard work? Is it a job description? Is it a standardized way of performing a task or process? Or is it routine working hours defined for the job requirements? So 28% of you voted, 40%. We're moving up quickly. Okay, 46% of you have voted. All right, so we're going to end the poll in the for time, but here are the results. So almost all of you gave the correct answer, a standardized way of performing a task or process. Once we figure out the how, and that's what you're working on right now, you're figuring out the how, it's very important to have a standardized way of performing this task or process that you can share with a new employee who's coming in. You can share with your team. You can audit and check and see if you're doing it the right way. One person said a job description, not so much. So we'll stop with our poll now, and we're going to do very quick run through of the reminder about standard work. And this is about the how to. So let's talk about standardization. And I'm going to remind you from learning session 2, and seeing these pictures just made me super happy. And I remembered what it was like when we could be together in a classroom. And I remembered your instructions to make a car from those Lego blocks. And I remembered how much fun we had doing that. And I remember you all being puzzled by all those pieces and working together to create a car. And so we asked which team's Lego blocks looked like a car. And do you all remember that some teams had a key element and some teams didn't? What was the key element that some teams had and other teams did not? Type into the chat box if you remember way back to January. What did some teams have and other teams did not? And I see Fizjani, well, we'll catch up with Fizjani's comment in a minute, but What did some teams have and other teams did not when we did this Lego exercise? Do you remember? Are you awake? Is anyone out there? This picture is a clue. Some teams had some key element and other teams didn't. An SOP, yes. Thank you, PSI Lab. Thank you, NMRL. Thank you, Medrizo. Some teams did not have an SOP. And these were what the directions or instructions looked like. And if you followed them step by step, you would end up with a beautiful car looking exactly like this every time, every team, if those directions had been followed. So standard work. This is what we can work on over the next month as we refine our test of change. We can work on putting them into a standard work that we can pass along and assure that we're doing the same way. So after we've defined, after we've measured, after we've analyzed and we've improved, we've been doing this PDSAs, we've been selecting a change. Now we want to make the change become standard work. There's something in your workbook. This is a fun video. And if we had time today, I would ask you to write some standard work directions, but we'll just watch the video for fun now.
次に左手でつまんだところから延長した肩とそのところを右手でつまみます。払って袖のところから折り込むようにして畳みます。きれいにできます。
So if we had time, I would get you to write some instructions for that standard work. And you realize it's not so easy to write instructions. And if we were all in person together, Katie would perform this in person and demonstrate the folding. But we don't have time for that today. But moving on, I'm going to whiz past you some examples of ways that you can set up an SOP, basically. You can put it in steps. There are even steps on how to milk a cow, okay? You can put it in standard steps and you can write an SOP on the basic milking procedure. You can write an SOP on how to feed cows, and you can use a bit of a graphics helping you see each step and then breaking it down. You can use pictures. This is from an airplane. They're telling us how to put on our oxygen mask or how to brace. This is a video on how to clean an endoscope, or there's a 111-page manual on how to reprocess and clean an endoscope. There are flow charts that tell us how to work, and there are SOPs, and this one is from our friends at NMRL, and this one is from our friends at PSI Lab. So let me tell you, if you want to know how to write an SOP, lab people do SOPs all the time. They're very, very good at it. So standard work. You can also show your standard work in a process map. Many of you have done changes to your process, and that can be demonstrated by showing an updated process map. This is one that Katie has put together. The old process is here. Here's the improved process, and she's breaking out a step down here so you can see the new client notification process. So very important to be able to have an old process and a new process. And again, cutting out waste, thinking of lean. So it's time for you to put all of these things together. From your current state, you can eliminate unnecessary steps. You can combine steps when practical. You can rearrange steps for a better sequence. You can simplify steps. And I think you'll remember very clearly also in that last time that we were together in learning session 2, we were able to improve that process of patients flowing through the emergency room and combine some steps. Remember, you put the tables all together so the steps would follow one another, and how you were able to increase flow. So create a new process map. So we are coming to the end. So really what we're wanting is this work that you've done and put together. We want it put together in a standard operating procedure. We want to see measurable results. Just moving back here 1 second, I'm going to ask you, I've got one more poll for you, and we will definitely be done by the hour. So here's a question about what format will you use to document your standard work? So this is for you all to answer. What format will you use to document your standard work? So this is really a question about what your final deliverables will be. All right, so 50% of you have voted, so in the interest of time, we'll end our poll. And the winner is a process map and a list of steps, or an SOP. Definitely want an SOP, but also would like to see that new process, how you've improved your process. And that can be many, different processes that you have improved. All right. So with that, are there any burning questions? Now I see Fajani has given us a response about airtime. Airtime became available in abundance after the peer reviewed, so it will not be a challenge. More calls will be made and follow up. PDSA will reveal outcome. So excited to look forward to that. Glad that that has been resolved. Appreciate you sharing that. So again, we are really nearing the end here. So what are you to do over the next 2 weeks before we meet again? A PDSA a week. And remember I said those PDSAs can be refining what you've already done, which of course you need to do, but you can also try something new or something different. But we just want to be doing some rapid testing and want to get that testing done. We want you, once you've got a stable process, we want you to write an SOP about how you've done that. And we want you to continue with your viral load challenge. I know we're trying to double what we did in August for the month of October. So we're right in the middle of October. So keep going on that challenge, doing whatever test of change you want to do that you think will improve those numbers. So questions. All right, we've got a couple responses here. No SOP. Someone mentioned teamwork, also very important. Everyone had teamwork though. What some teams had and other teams didn't was the SOP or the work instructions. So questions. Again, the end is approaching rapidly, so we'll want to, put some extra effort in over the next 4 weeks. So we will be able to to show some benefits and results? I'm not seeing any questions. While we're waiting for questions, I'll go ahead and launch the final poll. Tell us what you thought of the overall learning content of our webinar today. And we'll still entertain some questions. If there are any questions, be happy to entertain those. And we aren't sending out the full scale surveys anymore. So if there's something that you want us to improve on, we have another couple of times to meet together. So please, and if you want to submit that through Fortunate, and then she could share with us, we're certainly very happy always to be improving. We are about QI. So 69% of you have voted. And I think we are at 1 minute. So I will go ahead and close the poll. Here are our results. Now, if you gave us a 1, which means you were not satisfied at all, one person, please feel free to share what you would like us to do better. Share that with Fortunate and she will send it along. And even if you gave us a 3 in the middle there, definitely tell us what we could do to make it better. I want to end with a shout out to Ann and Patience and their team for sharing some amazing results in the work they've been doing. I want to give a hand to Jackie and the Mbare Poly team, strong work there. And I want to give a hand to Fajani and Cephas and Miriam and their team there at Seke North. Great work. Thank you so much for taking the time to share with us and help us learn. And with that, I will close out. Fortunate, you have anything to share as we close?
Thank you, Barbara. I don't have much except just to remind the coaches and the teams, can you please submit your Econet numbers to your coaches? I need them as soon as possible. So if you can submit your Econet numbers so that I can verify the numbers I have with the new list so that I work on your data. Because now we want to give you data, not the money, because people are not buying the data. So I want to give you the data. So we're trying to work something out with Econet. Thank you.
Thank you all for your attention. We'll sign off now. We'll see you in 2 weeks and 1 day on Thursday, November 5. Looking forward to that. Keep up the strong work. Keep testing changes. I've got clapping hands and a thumbs up from PSI Lab Samuel. Thanks.
So Barbara, remember to stop recording.
Okay, excellent.